Welcome to today's presentation. I'm Dr. Shafiq Ladha, the Ira A. and Mary Lou Fulton Chair in Motor Neuron Diseases and the Director of the Gregory W. Fulton ALS and Neuromuscular Disorder Center in the Department of Neurology at Barrow Neurologic Institute. Nexviazyme, avalglucosidase alpha, NGPT, is an alternative option for your patients with late-onset Pompe disease, or LOPD. This is an enzyme replacement therapy, or ERT, indicated for the treatment of patients 1 year of age and older with late-onset Pompe disease. In this presentation, you will learn how Nexviazyme can help your LOPD patients who are either beginning treatment or those switching treatment. Nexviazyme comes with a box warning. I'm going to take the next couple of minutes to read through that content. Hypersensitivity reactions, including anaphylaxis. Patients treated with Nexviazyme have experienced life-threatening hypersensitivity reactions, including anaphylaxis. Appropriate medical support measures, including cardiopulmonary resuscitation equipment, should be readily available during Nexviazyme administration. If a severe hypersensitivity reaction, for example anaphylaxis, occurs, Nexviazyme should be discontinued immediately and appropriate medical treatment should be initiated. In patients with severe hypersensitivity reaction, a desensitization procedure to Nexviazyme may be considered. Important safety information. Infusion-associated reactions, or IARs. Patients treated with Nexviazyme have experienced severe IARs. If severe IARs occur, consider immediate discontinuation of Nexviazyme, initiation of appropriate medical treatment, and the benefits and risks of readministering Nexviazyme following severe IARs. Patients with acute underlying illness at the time of Nexviazyme infusion may be at greater risk for IARs. Patients with advanced Pompe disease may have compromised cardiac and respiratory function, which may predispose them to a higher risk of severe complications from IARs. Risk of acute cardiorespiratory failure in susceptible patients. Patients susceptible to fluid volume overload, or those with acute underlying respiratory illness or compromised cardiac or respiratory function, for whom fluid restriction is indicated, may be at risk of serious exacerbation of their cardiac or respiratory status during Nexviazyme infusion. More frequent monitoring of vitals should be performed during Nexviazyme infusion. Late-onset Pompe disease, or LOPD, is a degenerative neuromuscular disorder. LOPD is caused by pathogenic variants in the acid alpha-glucosidase, or GAA gene, resulting in GAA enzyme deficiency. Subsequent GAA enzyme deficiency leads to impaired lysosomal glycogen breakdown. Accumulation of glycogen then causes damage to muscles such as the diaphragm, the proximal limb, and the paraspinal muscles. The degenerative nature of LOPD can cause irreversible damage, even with management. How does muscle damage translate to functional impairment? Well, respiratory muscle weakness results in difficulty breathing and respiratory infections. Patients may eventually even require mechanical ventilation. Respiratory dysfunction is the most common cause of death in LOPD. Proximal muscle weakness can result in difficulty ambulating and limited gross and fine motor skills. Ultimately, patients may require mobility devices and wheelchair use. This decline in respiratory and motor function can occur in any patient with LOPD, whether they have never been on treatment, also known as ERT naive, or currently on treatment or stopped treatment, also known as ERT experienced. A patient could decline at any time. Studies show that despite management, many patients declined after 3 to 5 years. Patients typically experience a period of benefit, followed by a plateau, and eventual decline. However, individual variances did occur. Considering that improvement or stabilization of respiratory function and walking capacity is the goal of LOPD treatments, a change in therapy may be needed for patients with LOPD. This brings us to Nexviazyme, which is an enzyme replacement therapy designed with approximately 15 mannose-6-phosphate residues per molecule. Let me begin by explaining the role of mannose-6-phosphate. M6P residues bind to receptors, mediating the uptake of ERT into muscle cells. Why are M6P residues important? Well, in healthy individuals, the GAA enzyme is produced within the cell, binds to the cation-independent M6P receptors, and is routed to the lysosome in a series of steps. On the contrary, in an individual with LOPD, there is GAA deficiency. As a result, exogenous GAA needs to be brought in from outside the cell. The approximately 15 M6P residues per molecule of Nexviazyme help with high affinity binding to the cation-independent M6P receptors to enable entry into the muscle cell. L-glucosidase alpha has approximately 1 M6P residue per molecule. Statistical superiority of Nexviazyme over L-glucosidase alpha was not achieved in a clinical study. So how does Nexviazyme make its way into the lysosome? The following steps are involved. It enters the body by intravenous infusion. M6P on the surface of Nexviazyme binds onto muscle cell receptors with high affinity. The binding of M6P with receptors helps internalize Nexviazyme into the cell and facilitates its transport to the lysosome. The M6P receptor complex dissociates and Nexviazyme enters the lysosome where it breaks down accumulated glycogen. Before we go into the efficacy and safety data, I want to summarize the pharmacodynamic data and Nexviazyme's role in glycogen degradation. In patients with Pompe disease, excess glycogen is degraded to hexose tetrasaccharides, including glucose tetrasaccharides, or GLC4, which are then excreted in the urine. GLC4 is the major component of HEX4. Treatment with Nexviazyme resulted in reductions of this urinary biomarker in patients with LOPD. This implies that glycogen is now broken down into simple sugars rather than being degraded to HEX4 when GAA enzyme is deficient in patients with LOPD. The mean percentage change in urinary GLC4 concentrations from baseline to week 49 was minus 54% and minus 11% in the Nexviazyme and the L-glucosidase alpha treatment groups, respectively. Note the clinical relevance of urinary GLC4 concentrations has not been determined. Now let's take a look at the phase 3 study comparing Nexviazyme with L-glucosidase alpha. The COMET study was a randomized, double-blind, multinational, multi-center trial comparing the efficacy and safety of Nexviazyme to L-glucosidase alpha in 100 patients with LOPD, open to patients aged 3 years and older at 56 sites across 20 countries. Patients were randomized in a 1-to-1 ratio according to baseline forced vital capacity, or FVC, gender, age, and country, to receive 20 milligrams per kilogram of either Nexviazyme or L-glucosidase alpha, administered intravenously once every 2 weeks for 49 weeks. As mentioned previously, in Pompe disease, both respiratory and motor functions are affected. The primary endpoint was change in FVC, percent predicted, in the upright position from baseline to week 49. FVC is the volume of air that can be forcibly blown out after a full inspiration. In restrictive lung disease, for example Pompe disease, FVC is often reduced. The key secondary endpoint was change in total distance walked in 6 minutes, or 6-minute walk test, from baseline to week 49. The 6-minute walk test provides a measure of functional exercise level required to undertake daily physical activities. The test is conducted by measuring the distance walked in 6 minutes and allows the patient to rest when needed. It varies with gender, age, and height. As late-onset Pompe disease progresses, people may not be able to walk as far due to muscle weakness. As for baseline characteristics of the 100 randomized patients, mean FVC, percent predicted, at baseline was 62.5% for Nexviazyme treated and 61.6% for L-glucosidase alpha treated patients. As context, normal adults have an FVC of around 80 to 120%. Mean 6-minute walk at baseline was 399.3 meters for Nexviazyme treated and 378.1 meters for L-glucosidase alpha treated patients. As a reference, 6-minute walk distance ranges from 400 to 700 meters for a healthy individual. Key inclusion criteria included Participants must be able to ambulate at least 40 meters without stopping and without an assistive device. Must be able to successfully perform repeated FVC measurements in the upright position of greater than or equal to 30% predicted and less than or equal to 85% predicted. In the COMET study, Nexviazyme improved both respiratory function and walking distance compared with baseline. Additionally, both the FVC and 6-minute walk test results favored Nexviazyme over L-glucosidase alpha. As mentioned earlier, the primary endpoint measured changes in FVC. At week 49, the least squares mean change in FVC, percent predicted, for patients treated with Nexviazyme and L-glucosidase alpha was 2.9% and 0.5% respectively. The estimated treatment difference was 2.4%, favoring Nexviazyme. Non-inferiority margin was 1.1%, p-value of 0.0074. Statistical superiority of Nexviazyme over L-glucosidase alpha was not achieved with a p-value of 0.06. The statistical significance threshold was 0.05. The secondary endpoint measured changes in the 6-minute walk test. At week 49, the least squares mean change from baseline in 6-minute walk test for patients treated with Nexviazyme and L-glucosidase alpha was 32.2 meters and 2.2 meters respectively. The estimated treatment difference was 30 meters, favoring Nexviazyme, with a nominal p-value of 0.04 that was not adjusted for multiplicity. I'd like to now describe the safety data in the COMET study. As you may recall, in the COMET trial, 100 patients aged 16 to 78 years with LOPD were treated with either 20 milligrams per kilogram of Nexviazyme or 20 milligrams per kilogram of L-glucosidase alpha, given every other week as an IV infusion for 49 weeks, followed by an open-label extension period. During the double-blind active control period of 49 weeks, serious adverse reactions were reported in 1 patient treated with Nexviazyme and 3 patients treated with L-glucosidase alpha. Infusion-associated reactions, or IARs, were reported in 13 of the Nexviazyme-treated patients. IARs reported in more than 1 patient on Nexviazyme were mild to moderate and are listed here. IARs were reported in 16 of the L-glucosidase alpha-treated patients. IARs reported in more than 1 patient on L-glucosidase alpha were mild to severe and are listed here. Severe IARs were reported in 2 patients treated with L-glucosidase alpha. Adverse reactions reported in greater than or equal to 6% of patients treated with Nexviazyme included headache, fatigue, diarrhea, nausea, arthralgia, dizziness, myalgia, pruritus, vomiting, dyspnea, erythema, paresthesia, and urticaria. The pooled safety analysis from 4 clinical trials included 141 patients treated with Nexviazyme, 118 adult and 23 pediatric patients, and with data up to 7 years. Serious adverse reactions of respiratory distress, chills, and pyrexia were each reported in 2 or more Nexviazyme-treated patients. Serious adverse reactions were similar across both adult and pediatric populations. A total of 5 Nexviazyme-treated patients in clinical trials permanently discontinued Nexviazyme due to adverse reactions, including 2 of these patients who discontinued the treatment because of serious adverse reactions. The most frequently reported adverse reactions, in greater than 5%, in the pooled safety population are listed here. IARs were reported in 48 or 34% of Nexviazyme-treated patients. IARs reported in more than 1 patient are listed here. I want to summarize the warnings and precautions here. Warnings and precautions. Hypersensitivity reactions, including anaphylaxis. Life-threatening hypersensitivity reactions, including anaphylaxis, have been reported in Nexviazyme-treated patients. Some of the hypersensitivity reactions were IgE-mediated. Anaphylaxis signs and symptoms included respiratory distress, chest discomfort, flushing, cough, erythema, lip swelling, pruritus, swollen tongue, dysphagia, and rash. Symptoms of severe hypersensitivity reactions included respiratory distress, erythema, urticaria, tongue edema, and rash. Increased incidence of hypersensitivity reactions was observed in patients with higher antidrug antibody titers. Prior to Nexviazyme administration, consider pretreating with antihistamines, antipyretics, and/or corticosteroids. Infusion-associated reactions. In clinical studies, IARs were reported to occur at any time during and/or within a few hours after the Nexviazyme infusion, and were more likely to occur with higher infusion rates. IARs that led to treatment discontinuation were chest discomfort, cough, dizziness, erythema, flushing, nausea, ocular hyperemia, and respiratory distress. Increased incidence of IARs was observed in patients with higher ADA titers. Antihistamines, antipyretics, and/or corticosteroids can be given prior to Nexviazyme administration to reduce the risk of infusion-associated reactions. However, IARs may still occur in patients even after receiving pretreatment. Risk of acute cardiorespiratory failure in susceptible patients. Patients susceptible to fluid volume overload, or those with acute underlying respiratory illness or compromised cardiac or respiratory function, for whom fluid restriction is indicated, may be at risk of serious exacerbation of their cardiac or respiratory status during the Nexviazyme infusion. More frequent monitoring of vitals should be performed during Nexviazyme infusion. Some patients may require prolonged observation times. Adverse reactions. The most common adverse reactions, greater than 5%, were headache, fatigue, diarrhea, nausea, arthralgia, dizziness, myalgia, pruritus, vomiting, dyspnea, erythema, paresthesia, and urticaria. The recommended dosage of Nexviazyme is 20 milligrams per kilogram for patients weighing 30 kilograms or more, 40 milligrams per kilogram for patients weighing less than 30 kilograms, and given every 2 weeks through IV infusion. With a large 100 milligram vial, 50% fewer vials are needed for reconstitution at the 20 milligram dose. Prior to Nexviazyme administration, consider pretreating with antihistamines, antipyretics, and/or corticosteroids. Nexviazyme must be reconstituted and diluted prior to use. The initial recommended infusion rate is 1 milligram per kilogram per hour. Gradually increase the infusion rate every 30 minutes if there are no signs of infusion-associated reactions. See full prescribing information for administration instructions, including the recommended infusion rate schedule and dosage modification due to hypersensitivity reactions, or IARs. Before wrapping up, let's take a look at 3 different LOPD patient case profiles and assess whether Nexviazyme is right for them. Meet Josh. Josh was diagnosed with LOPD just 4 weeks ago. He is not taking any LOPD therapy currently. Josh has experienced a combination of motor and respiratory symptoms for the past 5 years and has seen a variety of specialists before finally being diagnosed. He complains of increasing stumbling and falling, as well as greater difficulty climbing stairs. Josh experiences shortness of breath after a long walk, and he has proximal and axial muscle weakness and back pain. Here are his recent select clinical assessments. His FVC is 72%. His 6-minute walk test is approximately 360 meters. His Hex4 level is 12 millimoles per mole of creatinine. Consider whether biweekly Nexviazyme may be appropriate for your newly diagnosed or untreated patients like Josh. Next, meet Maria. Maria was diagnosed with LOPD 8 years ago, and she has been on L-glucosidase alpha since her diagnosis. Maria's shortness of breath has increased over the last 2 to 3 years. She has required an increased BiPAP pressure setting ever since she started waking up with morning headaches. Now she's unable to lie down without her BiPAP machine. Starting 4 years ago, Maria has needed to use a walker all the time. She has been falling more frequently over the past year. In short, she has clear worsening of her symptoms. Here are some of her recent lab findings. Her FVC is 61%, It was stable for 5 years, but decreased 5% in the last 3 years. Her 6-minute walk test is approximately 315 meters, which has progressively decreased by around 30 meters over the last 5 years. Her HEX4 level is 8 millimoles per mole of creatinine, which was 6 millimoles per mole of creatinine 1 year ago. Even with management, a patient could decline at any time. Consider whether biweekly Nexviazyme may be appropriate for your patients in your practice like Maria. Last but not least, meet Tim. Tim was diagnosed with LOPD 3.5 years ago. Since diagnosis, he has been on L-glucosidase alpha. Tim reports that his symptoms are unchanged since his last visit. However, upon further questioning, he admits to having trouble getting up from a seated position, similar to his pre-treatment baseline. From a respiratory function standpoint, he still uses his BiPAP machine all night long. As you know, at times, patients can be oblivious to changes they are seeing. This is why it is essential to listen to and observe for slight changes in your patients over time. Here are Tim's recent select clinical assessments. His FVC is 67%, which has decreased by 4% in the past 1 year. His 6-minute walk test is approximately 398 meters, which has decreased by 30 meters over the last year. His HEX4 level is 5 millimoles per mole of creatinine, which has been stable since last year. Because a decline in respiratory and motor function can occur in any patient with LOPD, whether ERT naive or ERT experienced, consider whether biweekly Nexviazyme may be appropriate for your patients like Tim. Sanofi Genzyme's support services represent more than 35 years of commitment to supporting the rare disease community. Transitioning to Nexviazyme can be a seamless process. Patients can receive Nexviazyme at their regular infusion center, and copay and financial assistance are available for eligible patients, similar to L-glucosidase alpha. For more information about Nexviazyme or for additional resources, visit www.nexviazyme.com/HCP. Sanofi Genzyme may be able to help your patients start treatment. Your patients may be eligible for CareConnect PSS Quick Start program. Patients can receive Nexviazyme at no charge while their insurance authorization is being reviewed. Certain eligibility restrictions do apply. Visit www.nexviazyme.com/HCP or call 1-800-745-4447, option 3 for more information. In conclusion, Nexviazyme is an ERT that is approved for the treatment of LOPD. Nexviazyme binds to M6P receptors on the cell surface with high affinity and is internalized and transported into the lysosomes, resulting in breakdown of glycogen. Nexviazyme demonstrated a reduction in urinary HEX4 levels. The detection assay measured GLC4, which is a major component of HEX4. The clinical relevance of urinary GLC4 concentrations has not been determined. Nexviazyme is indicated for the treatment of patients 1 year of age and older with late-onset Pompe disease. In a 49-week head-to-head clinical trial in late-onset Pompe disease, Nexviazyme exhibited improved respiratory function, improved walking distance, and a demonstrated safety profile. Last but not least, consider Nexviazyme in both treatment-naive and treatment-experienced LOPD patients. Here are some frequently asked questions we've been receiving in regard to Nexviazyme, and I will try to address these questions one by one. The first question is, how should one keep track of an LOPD patient's disease progression? Are there any tests and/or physical exams that are ideal for monitoring decline in these patients? Monitoring of LOPD is simple, but in my view requires certain key components. Performing respiratory function tests, like the FVC, the MIP and MEP, in collaboration with your pulmonologist and/or respiratory therapist are critical. Muscle function tests that can be performed in your office. I'm aware that not all centers have easy access to performing 6-minute walk tests or access to a multidisciplinary team. Finally, I cannot emphasize enough how important it is to listen to and observe for slight changes in your patients over time. I tend to do that by ensuring I ask them how they're feeling and whether certain tasks are more difficult than they used to be. Closely monitor whether your patients can no longer do the things that they were doing. For example, climbing stairs, dressing themselves due to weaker shoulder muscles, limiting food intake due to swallowing issues, getting up from chairs, experiencing shortness of breath over time, or getting winded while walking. Closely observe for signs of sleep-disordered breathing, such as morning headaches or excessive daytime fatigue. In general, regular follow-ups are important for monitoring for decline. Is there a washout period between switching from Lumizyme to Nexviazyme? No, a washout period is not necessary based on trial experience in the extension phase of COMET. We need to ensure that treatment continues until they are actually able to switch. When is the right time to switch a patient to Nexviazyme? Nexviazyme is indicated for the treatment of patients 1 year of age and older with late-onset Pompe disease. So any of your Pompe patients that meet these criteria can be a candidate for switching to Nexviazyme at any time. Since Pompe disease is a progressive disease and muscle, once lost, cannot be regained, one shouldn't wait for worsening of symptoms to occur prior to making a change. Across multiple long-term studies, data have shown that even with management, the exact onset of secondary worsening of symptoms can be unpredictable. Many patients showed a worsening of symptoms after 3 to 5 years. In other cases, your patients may be oblivious to the changes occurring with their functional status, so following their disease progression and listening to your patients and looking out for even the slight changes in their symptoms over time is important. In terms of safety, could you comment on whether trials showed any neutralizing antibody response in patients? As with all therapeutic proteins, there is a potential for immunogenicity with Nexviazyme as well. There were incidences of both neutralizing antibody types, enzyme activity and cellular uptake, among 13 out of 61 Nexviazyme-treated adult and pediatric treatment-naive patients, and 3 out of 58 treatment-experienced adult patients. No clear trend of anti-drug antibody, or ADA, impact on pharmacokinetics was observed. A trend toward decreased pharmacodynamic response as measured by % change of urinary glucose tetrasaccharides from baseline was observed in patients with ADA peak titers of greater than or equal to 12,800. The development of ADA did not have an apparent impact on clinical efficacy. In Nexviazyme-treated patients, the incidence of IARs was 62%, or 8 out of 13, in those with ADA peak titers of greater than or equal to 12,800, compared with incidences of 19%, or 8 out of 43, in those with ADA peak titers of less than 12,800, and 33%, or 1 out of 3, in those who were ADA negative. Increased incidence of hypersensitivity reactions was observed in patients with higher ADA titers, 4 out of 13, or 31%, compared with lower ADA titers, 2 out of 14 and 14%. One treatment-naive patient and 2 treatment-experienced patients developed anaphylaxis. ADA cross-reactivity studies showed that antibodies to Nexviazyme are cross-reactive to L-glucosidase alpha. Thank you for viewing this introduction to Nexviazyme, avalglucosidase alpha NGPT.